right. And then just started recording the meeting for the folks who won't be able to attend, or if we need to go back and reference. Good morning, everyone. Happy New Year. We have a few housekeeping items to discuss, and then we will turn it over to Dr. Brandt. But if everyone could go ahead and again introduce themselves in the chat, say who's here and where you're from. I know we'll have a lot of folks on the call today, so we want to spend as much time as possible with the topic of the day. And then Elsa, did you have a few reminders and things that you wanted to talk about before we get started?
Sure. And yeah, nice to see people saying hi in the chat, and of course our representation from all over the state. So thanks so much everyone for taking the time today for our first call in 2023. Since we are now halfway through the year and through the first full 2 quarters of the fiscal year, and about to submit our quarterly report to CDPHE, I've sent out a couple reminders about evaluation, but just to make sure everyone is aware, all Q2 data is due tomorrow or today, by the end of the day today, the 10th, submitted in Qualtrics for the colonoscopy navigation work. And then if your clinic is involved in any of our stool testing, hereditary cancer, or lung cancer screening projects, please send that data to me directly in an email. And of course, if there's any questions or if you're expecting any delays, please reach out to me in an email as well, and I'd be happy to support. But really, really appreciate all of the work you all have put in over the last quarter. And it looks like there's been great gains in reaching the communities. And then secondly, I also just wanted to let everyone all know, if you're on our Alliance newsletter list, you may have seen this, or the Colorado Cancer Coalition, but the Colorado Cancer Coalition is having their winter quarterly meeting on January 24th from 11 to 1, and Andy as well as Patty from the Patient Navigation Training Collaborative are both on the agenda for that meeting, where they'll be sharing about the new grants that have been received for community health work and patient navigation training, and also other opportunities in the state. That meeting is going to be both virtual and also in person on the Eastern Plains in Burlington. So if you are in that area of the state, opportunity to join in person. Otherwise, we definitely encourage you all, if you are available, to join for all or some of the agenda virtually as well. So I'll put the link in the chat to register for that meeting along with the agenda. But check that out. There'll also be some information about what's on the 2023 agenda for cancer legislation and some other updates across the state. So now I'm going to turn it back over to Wesley to introduce our speaker for today.
Great. Thanks, Elsa. And I'll send out those links and information in the follow-up email as well. So today we have Dr. Heather Brandt coming to speak with us about increasing HPV vaccination coverage for cancer prevention. January is Cervical Cancer Awareness Month, and she works with HPV vaccination coverage and prevention at St. Jude's Children's Research Hospital, and has a great presentation for us today. So Dr. Brandt, take it away.
Thank you, Wesley, and thank you, Elsa, for extending this invitation to me. So how I met Andy Dwyer was actually through my work in colorectal cancer screening. I worked in that space for about 15 years before transitioning to this new role at St. Jude a couple of years ago. Pandemic time seems a little bit hard to put exact months and years, but it's been a couple of years since I've transitioned out of doing a lot of work in colorectal cancer screening and into focusing solely on HPV cancer prevention. As Wesley indicated, January is Cervical Cancer Awareness Month, or Cervical Health Awareness Month. And it just is a time to start out the new year with a new sense of urgency about what we can do to prevent cervical and other HPV types of cancer. So today I'm going to share information with you. I welcome your questions. Please post them in the chat. Please come off mute at the end and ask them. I want to make sure I'm giving you information that is not only of interest to you personally and professionally, but also relevant to the important work you're doing to improve cancer prevention and control in the communities you're serving. So before I get started officially, I do have no disclosures. So today I'm going to talk a lot about HPV cancer prevention. I'm going to weave in some cervical cancer information since we are celebrating that month. And I say celebrating because we're celebrating the important contributions of women as well as the survivors to this life-saving cancer prevention activity that women can engage in through vaccination and also through early detection like cervical cancer screening, following up on abnormal results, and ensuring timely treatment as well. So before I get started today, I always like to give some seconds to Henrietta Lacks. Every data point I'm going to share with you today represents a person, someone who's known and loved and whose life mattered. And one of the people most responsible for HPV cancer prevention is a woman named Henrietta Lacks. And we recently commemorated the 70th anniversary of her death. And I want to mention her specifically because the reason we know that HPV is linked to cervical cancer and other types of cancer is because of the immortal cells of Henrietta Lacks. And Henrietta Lacks was recently in the news at the end of last year because in Roanoke, Virginia, her hometown, they are going to replace the former statue of Robert E. Lee with a statue of Henrietta Lacks because of her significant contributions, unbeknownst to her and unbeknownst to her family until the last several years, but her tremendous contributions to science and medicine. We wouldn't have a polio vaccine. We certainly would not have COVID-19 vaccines. And we definitely would not understand the link between HPV, cervical, and other types of cancer without Henrietta Lacks. So if you haven't heard of her before, take a few minutes to Google her. And there's an excellent book written by Rebecca Skloot on the immortal cells, the immortal life of Henrietta Lacks, and also several really great articles that are available out there to learn just about how significant her contribution has been to science and medicine. So let me get started a little bit with how common HPV is. We hear a lot about HPV and maybe it's really, really common, but cervical cancer and the 5 other types of cancers that are linked to HPV maybe seem a little bit less common, but we know that HPV infection prevalence has declined since the implementation of HPV vaccination in the United States. And the results that I'm going to share with you today from various studies about just how common HPV is makes us start to think about something so common that causes a lot of problems and is very costly can almost all be prevented with timely HPV vaccination. So first, here's an overview of just general prevalence in the United States. So HPV is passed from one person to another through intimate sexual contact, skin to skin contact, and you can see HPV is very, very common. It is in fact the most common sexually transmitted infection in the United States. And when you look at just how common it is nearly 3 times as common as herpes simplex virus, HSV, or just herpes is in the United States. So this means that in the United States, 8 out of every 10, 4 out of every 5, however we want to slice it, Americans are going to acquire an HPV infection at some point in their life. So it is an incredibly common infection. And unfortunately, it's so common in many healthy people, they're able to get rid of it. It doesn't cause any problems. Not in all healthy people, and some healthy people it does cause problems. But overall, because of how common it is, most people are able to clear it, is the phrase that's used, and it doesn't result in any problems at that time. But the prevalence of high risk types of HPV, these are the types that are linked to cancer. And these are so common as well. About the prevalence is about 23% in the United States. And the prevalence of these high risk HPV types are highest among men and among people who are non-Hispanic and Black. And so overall, we see really high prevalence among men. This is probably something that if you don't know, some of what I'm going to share with you today is surprising, especially since cervical cancer, a cancer that affects women or people who have a cervix, yet men have the highest prevalence of high risk types of HPV, the types that are linked to cancer. Well, yes. And so it's why today you'll hear me say several times how important HPV vaccination is for everyone, because certainly men are affected just as much as women. HPV is also very, very expensive. It is second only to HIV in terms of how costly it is when we look at healthcare dollars and overall healthcare expenditures annually in the United States. So $775 million are spent each year in treating diseases caused by HPV. So I always like to include a global perspective because the center of the earth isn't necessarily where we have our feet planted at any given moment. So globally, this is an issue as well. And you'll see that worldwide, among females only, prevalence is about 12%. And you can see various regions, including the Caribbean, Eastern Africa, and Eastern Europe, have significantly higher prevalence. And again, these global perspectives are among females only, but you'll see that many regions have these much, much higher prevalence rates, which in turn lead to much, much higher disease rates. So take-home messages, HPV is very, very common. Almost everyone is going to have an HPV infection at some point in their lifetime. We don't yet know in whom having HPV, specifically one of these high risk or cancer causing types of HPV, is going to lead to a precancer or a cancer. But we do know that on-time HPV vaccination can prevent 90% of HPV cancers and almost 100% of cases of cervical cancer specifically. So let's talk a little bit about where we have opportunities for prevention in addition to vaccination. So in spite of high HPV prevalence, the burden of HPV-associated diseases, and the availability of a safe, effective, and durable vaccine, in the United States, HPV vaccination coverage has been quite low with great regional and population variability. And most cancers caused by HPV are almost entirely preventable. And each year in the United States, there are about 37,000 people who are diagnosed with a cancer caused by HPV infection. And globally, that number is much, much larger. So although cervical cancer may be the most well-known of these cancers caused by HPV, cervical cancer is just the tip of the iceberg. Cervical cancer is the only type of HPV cancer with a recommended screening test to detect it at an early stage. So a pap test or an HPV test or both, which is called co-testing. But the other types of HPV cancers may not be detected until they cause health problems. And so HPV vaccination, again, can prevent more than 90% of these cancers caused by HPV and can prevent almost 100% of cervical cancers from ever developing. It's also important to note that hundreds of thousands of women each year in the United States are diagnosed with precancers of the cervix. And there are estimated to be more than 500,000 cases of genital warts, plus thousands of cases of recurrent respiratory papillomatosis. So the cancer prevention potential is awesome. And so is protection against these other types of HPV diseases. So when you add up all of those different 6 types of cancer, plus precancers, plus genital warts, plus RRP, we're closing in on nearly 1 million people each year who are affected by HPV and have a disease outcome, whether it be of the cancer type or whether it be genital warts. So lots of opportunity for us to prevent those diseases with a vaccination that is safe and works really well. So I mentioned earlier about the global number being much, much higher. Well, globally, there are about 630,000 cases of HPV cancers each year. And this huge number is driven primarily by cervical cancer and the absence of vaccination, screening, and treatment programs. We are very fortunate in the United States to have the resources available to us through the National Breast and Cervical Cancer Prevention Program, Early Detection Program. We also are very fortunate within many of our states to have resources allocated in addition to those national funds to be able to focus on screening and timely follow-up care and treatment. That's just not the case in many places around the world. And so the potential globally is even greater for HPV vaccination to be a game changer. And the World Health Organization has committed to cervical cancer elimination and has enacted a strategy focused on increasing vaccination screening and timely treatment. So in the US, again, more than 37,000 cases. These cases, also consistent with global estimates, are largely oropharyngeal and cervical. And you should note that the number of oropharyngeal cancer cases exceeds the number of cervical cancer cases caused by HPV. So oropharyngeal cancer is the most common HPV cancer in the United States. It surpassed cervical cancer a few years ago, and more to come on this. But of course, it primarily affects men or affects males, as you can see here. So when we look at the data, the most recently available data for HPV cancers in the United States, these data are from 2019. And you can see here that there are parts of the country where there's almost a concentration of these HPV cancers, as shown by the darker or more saturated blue areas. So the leaders in the United States for HPV cancers are Arkansas, Kentucky, West Virginia. So 3 sort of mid-southern, southern states. And when we look at what drives these, it's often driven by cervical cancer. So here we see even deeper penetration in similar areas, south, mid-south, southeast. And we also see the Intermountain West with Wyoming, for example, as a state that is seeing high numbers, high rates of cervical cancer as well. So it is Cervical Cancer Awareness Month, and in the United States, recently published articles have actually shown that overall cervical cancer cases continue to decline, but the advanced cases, the invasive cases in the Falcaro et al. Article actually show an increase in the number of invasive cases. That's not good news, and that's a high indicator of poverty and other social determinants of health that are really creating challenges for continued cervical cancer screening and early detection efforts in the United States. So back to my earlier point, as I mentioned, oropharyngeal cancers have surpassed cervical cancers as the most common HPV cancers. And this change happened a few years ago. About 83% of HPV oropharyngeal cancers are diagnosed among men. particularly among white men. So the key to HPV cancer prevention is on-time HPV vaccination at ages 9 to 12, completion of the series by the 13th birthday. And HPV vaccination will absolutely help prevent oropharyngeal cancers in men. But we're not going to realize those benefits for many years. And this is really due to a lack of vaccination among this age group. And so it may take us 20 plus years to see any benefits because of the slow uptake or slow coverage of HPV vaccination. So what does this really mean? Well, it means HPV vaccination is for everyone, not just for girls or women because of cervical cancer, which is often, if anybody knows anything about HPV, that's what they know and that's what pops into their head. HPV vaccination is for everyone. And we especially have seen these surges in oropharyngeal cancers caused by HPV among white men and also in rural and frontier populations. So framing HPV vaccination as a vaccine to prevent cervical cancer is really missing the opportunity to prevent oropharyngeal cancers among everyone, among both males and females, and also the large proportion of other cancers and other diseases that HPV is linked to. So let's put a face to some of these numbers and some of these images. So this here is Superman HPV Jason Mendelson. And last summer, I had a chance to do a tweet chat on Twitter with him featuring one of our St. Jude partners. Jason Mendelson is an HPV cancer survivor, an advocate, and a father. And here he shows off the inside of his suit jacket, which has photos of his wife, children, and family. And he openly shares about how his stage 4 tonsillar cancer diagnosis linked to HPV, caused by HPV, really resulted in life-shattering and life-changing approaches to how he lives each day, including recording goodbye, farewell videos for his children. He is just a very powerful HPV cancer survivor and one who uses his story to tell the story about the prevention potential of HPV vaccination, along with the importance of those who weren't vaccinated or who were unable to be vaccinated in making sure they're having regular checkups and, if anything is found, following up in a timely manner. And I also want to share Kimberly Williams with you. Kimberly is a cervical cancer survivor, and anyone with a cervix is at risk of cervical cancer. And almost all cervical cancer cases are caused by HPV. Each year in the United States, there are about 13,000 new cases of cervical cancer diagnosed in the US. And current recommendations for cervical cancer screening are for women ages 21 to 39 to be screened every 3 years with just a Pap test. But once women hit age 30 through age 65, screening every 3 years with just a Pap test, or every 5 years with high-risk HPV testing alone, or every 5 years with high-risk HPV testing with a Pap test called co-testing. And these guidelines are currently under review. These are the guidelines from the U.S. Preventive Services Task Force. And so these guidelines are currently under review to make sure that we're not going to miss cases of cervical cancer, especially with our highly organized screening programs, timely adherence to follow-up care and treatment as well. So Kimberly recently, along with Jason, participated in our St. Jude HPV Cancer Survivors School, which was held last fall here in Memphis. There's a photo of all of us with our cancer survivors and our St. Jude team and our partner, Survivor Inc. So Kimberly is also very active in Survivor Inc. That's CERVIVOR, started by Tamika Felder, and is an outstanding organization designed to help support cervical cancer survivors, to help them navigate their treatment and survivorship journey, and also to reduce the stigma associated with cervical cancer. So wonderful organization. They have a great event happening this month. There's still time to participate, called the PAP Rally. So not a PEP rally, but a PAP rally, like the PAP test, to encourage community and connection through their activities. So check them out if you're unfamiliar with this organization. I know we have several active survivors in your region, your part of the country, who you may be aware of. It's a great group. So more than 37,000 people diagnosed each year in the US with an HPV cancer. Oropharyngeal cancers are the most common. Nearly 200,000 females each year diagnosed with a precancer of the cervix. And HPV vaccination really is for everyone. It's a very safe and effective vaccination. It works incredibly well. We have loads of data to show us just how well HPV vaccination is working. Sorry about that. My mouse just switched back. Let me get to my next slide. All right, so now let's talk a little bit about HPV vaccination more specifically and this path to prevention. So on time, HPV vaccination is at ages 9 through 12. Completion of the HPV vaccination series by the 13th birthday. Then there's late vaccination at ages 13 to 14, where you still get 2 doses. And then there's an extra dose. Not only is it late, but it's late plus there's an extra dose. And these age guidelines were developed based on our evidence, our behavioral evidence of what happens in the United States about when young people, whether we like it or not, or want to talk about it or not, as a part of normal human growth and development, young people are engaging in activities that could make them susceptible to acquiring an HPV infection at younger ages. And so that's why 9 to 12 is on time. We know if we can vaccinate children in that 9 to 12 window, we're going to catch almost all of them before they're engaging in behaviors that could make them susceptible, put them at risk for acquiring an HPV infection. So that's why these ages are determined. We also know that there is a highly immunogenic, robust response to HPV vaccination at this age that affords long-lasting, lifelong protection against HPV cancers and other diseases. So these are the CDC Advisory Committee on Immunization Practice Guidelines. And here is the American Cancer Society guidelines. So the American Cancer Society guidelines do focus also on that 9 to 12-year-old age group. And they also recommend everybody through age 26 going ahead and getting vaccinated. But unlike the ACIP guidelines, the American Cancer Society does not recommend HPV vaccination for those between 26 and 45 years. And there are a wide range of reasons if you're interested in why that's not recommended. There's no harm. And again, the CDC Advisory Committee on Immunization Practices recommends, or says if you weren't vaccinated as a child, talk to your doctor. You can still get vaccinated in this older age group. But the ACS says, no, we want to focus on this younger age group. Those folks who are older are likely already exposed. Many of those people who are already exposed might get vaccinated. It's a preventive vaccine. So if you're already exposed, you could still develop diseases. And so there's just a range of reasons why they recommend against it. But there's no harm in getting it. It's very safe. Talking with a healthcare provider in that age group will be useful. So here's what HPV vaccination initiation, that means somebody's had at least 1 dose of HPV vaccine. And you might remember back to that HPV cancers map that I showed you. And that map had basically similar areas here with low HPV vaccination coverage with the highest HPV cancer burden. So low HPV vaccination coverage and a high HPV cancer burden. So we have a really long way to go to make sure that some of these states that have the lowest HPV vaccination coverage, predominantly here in the South and also somewhat in the Intermountain West. To achieve these goals, the Healthy People 2030 goal is 80%. And if you look at a state like Mississippi, which is around 33%, that is a long climb to get to 80%. So how can we support their incremental increase to get them closer? And other states as well, including, I'm sitting in Memphis, Tennessee right now. Tennessee falls about 25 to 30 points below that 80% recommendation as well. So there's a lot of work to do. And St. Jude has recently brought together 12 southeastern states plus Puerto Rico to focus our efforts in this space and understand how we can learn from each other and address common challenges to improve coverage. So here's another look. So HPV vaccination, when it's given at ages 11 and 12, is part of something called an adolescent platform or a bundle of vaccinations that are all recommended for 11 to 12-year-olds, usually entering into 7th grade. Each state, every state requires Tdap or pertussis, and about all but 16 states require meningitis vaccination, and only 3 states require HPV vaccination at this similar age point. But the take-home message here is when we look at those other vaccinations also recommended in that 11 to 12-year-old age group, we see that HPV vaccination is by far the lowest. So people in this age group, adolescents in this age group, are getting all of these other vaccinations, but not getting HPV vaccination. And HPV vaccination it's safe, it works, it provides long-lasting protection, but other vaccinations, such as those required for school entry, appear to be prioritized in comparison to others. We also see differences in vaccination when we look at urbanicity and rurality. So children who live in rural areas consistently have lower HPV vaccination coverage. And we recently took a look at some state level data in Missouri, for example. And in Missouri, the rates of children living in rural areas who've had HPV vaccinations is about half of what it is compared to the rest of the state. So huge gaps, huge differences, huge opportunities to build on what does exist with rural and frontier communities to understand how we leverage trusted relationships and message about HPV cancer prevention, build confidence in HPV vaccination for people who are living in these areas. Let's take a look here about public insurance. So something that has been a phenomenon with HPV vaccination since it was first introduced in the United States in 2006 is that children who are publicly insured have higher HPV vaccination coverage than children who are privately insured. And I always refer to this as a problem of privilege. Children who are publicly insured may have fewer encounters with a healthcare provider. They may have parents and caregivers who are unable to get them in for multiple visits, whereas children who are privately insured may reflect privileges that those publicly insured do not have. And so in instances like this, seeing these differences, it's truly reflecting the privilege of choice, decision, when a child goes for a vaccination, if at all in this case. And so this is a challenge that we recognize and have been trying to understand and really peel away the different layers about why children who are publicly insured are not getting vaccinated at the same level as those children who are publicly insured. And then when we look here, similarly, you would expect this to follow children who are below the poverty line, just as with children who are publicly insured, they have higher HPV vaccination coverage as well. So you've heard me refer to on time, you've heard me refer to the 9 to 12-year-old age group. That's because starting HPV vaccination at age 9 has emerged as a really important strategy for HPV vaccination initiation and completion. And the American Academy of Pediatrics and the American Cancer Society, as well as us at St. Jude, we emphasize the importance of beginning HPV vaccination at age 9. There are so many benefits supported by research studies, and a few are just cited here. And we're currently working with the National HPV Vaccination Roundtable, the American Cancer Society, and the journal Human Vaccines and Immunotherapeutics on a special issue that compiles the evidence of how important it is to start at age 9 to make sure children are completing the HPV vaccination series by age 13. On time is where we want to be, and on time is what we're promoting with HPV vaccination. And that's because when we start to look at the benefits of HPV vaccination, we start to see how important it is to be vaccinated at these earlier ages on time. And this was a big study that came out about a year ago, a little bit more than a year ago. And it showed how important it was to be vaccinated by age 13. It showed incremental decreases in how well someone was protected as they got older in these age cohorts. And that reflects the likelihood of exposure, because this is a prophylactic or preventive vaccine, not a therapeutic vaccine. And this is just one of many studies that exist that show how important it is to start HPV vaccination at age 9. For some families, 11 to 12 is going to work. They accept vaccinations. They're ready for what the healthcare provider recommends, what the CDC recommends. But I suspect you've worked with people in communities where there's distrust of government. There's uncertainty about vaccinations overall here in the era of COVID-19 vaccines. And so starting at age 9 can help to build confidence, having that conversation over time to allow the parent or caregiver or whomever's making the vaccination decisions in a family to ask questions and get those answered, and hopefully ensure that as many children, all children, are vaccinated on time by their 13th birthday. The National HPV Vaccination Roundtable website has a whole suite of resources available about starting at age 9 that you can tackle and use. Really great stuff, really nice resources and materials just ready to be used. So when we take a look at HPV vaccination coverage, the incidence of HPV cancers, we have a major opportunity for impact by increasing HPV vaccination today to prevent HPV cancers in the future. HPV vaccination is safe, it's effective, and it's durable, yet coverage is less than optimal. And what's particularly concerning is that low HPV vaccination coverage in areas where HPV-associated disease burden is the greatest. So that's a big concern, where we see low coverage and high disease burden. So just a few more things I want to cover today before I get to your questions. First is the effects of the pandemic. I alluded to the era of COVID-19 vaccines and the need to build confidence in HPV vaccination and combat widespread misinformation and disinformation efforts to undermine the safety and effectiveness of HPV vaccination and other vaccinations has never been more timely and critical. And all of you who have joined today, or those of you who are viewing this recording, all of you are in positions of influence. People know you have something to do with healthcare. And so you emerge as a potentially trusted messenger for answering their questions, for directing them to answers to their questions. And that's incredibly important, because we don't want to lose hard-earned gains as a result of the pandemic. And we've already seen some of those gains being lost. And we know that with measles outbreaks, which are currently happening because of vaccination questions, because of the pandemic effect on access points for vaccinations, chickenpox, the Washington Post recently had an article about measles, and chickenpox resurgences as a result of maybe parents and caregivers delaying vaccinations, which is understandable. I think back to the early days of the pandemic when parents and caregivers were tasked with trying to figure out how to keep a job, how to be an essential worker, but now their children aren't in schools. A lot on their plates. But now is the time. There's never been a better time to help people get back on track with routinely recommended vaccinations to keep kids, families, schools, and communities safe from vaccine preventable diseases. So when we think about what have we lost, well, an article by Saxena and colleagues said it may take up to 10 years to get back on track with vaccination doses missed during the course of the pandemic. And this covered about a 2-year period from March 2020 to March 2022. That is a really long time to play catch up. And that's not to catch up to get to the healthy people goal of 80%. That is to get back to the baseline levels prior to the pandemic, which, as we know, in most states fell well short of that healthy people goal. So when we take a look at vaccines for children program ordering data, these are from the end of summer last year, we still see lower ordering coming in for vaccinations, which is a concern because lower ordering means less supply equates to less demand and fewer children getting vaccinated. So there's definitely an opportunity here to improve. HPV vaccination is safe, it works really well, and it provides long-lasting protection. And on-time HPV vaccination is best. And we want to make sure we're reaching everyone, especially people who may fall into one of those populations that is experiencing widespread inequities, to make sure that we're able to address that. And your voices are important in this process. And so please feel free to use the resources that you have available to you in your state and your region and community, and feel free to use our St. Jude resources as well. So let's talk about how do we move forward with preventing these cancers through intervention implementation. And we see a range of different settings in which interventions can happen and operate. And we think about clinical settings, community settings, policy approaches that are important, equity, and also partnerships. And one of the biggest threats to vaccinations overall, and especially HPV vaccination, COVID-19 vaccinations, and seasonal influenza vaccinations is vaccination hesitancy. And this has been heightened as a result of the pandemic, and likely conflation is happening with routinely recommended vaccinations overall. So vaccine acceptance occurs on a continuum, with a level of vaccine confidence and acceptance, with refusing all vaccines on one end and accepting all vaccines on time or as recommended at the other. So when we start to peel back and understand what underlies vaccine hesitancy, this really refers to the acceptance or refusal of vaccination despite having the availability of vaccination. And vaccine confidence looks at factors like the trust that parents, caregivers, patients, and healthcare providers have in recommended vaccinations, so the vaccines themselves, the providers or people who administer vaccines, and the processes that led to vaccine licensure and recommendations. And the most trustworthy source of vaccination information for parents and caregivers consistently is healthcare providers. And people have questions now about vaccines, questions that I could not have ever imagined previously, and we could not plan for as a result of the influence of COVID-19 vaccines and the pandemic. But that's here, and we've got to figure out how to answer those questions that people have. And vaccine hesitancy is prevalent. Prior to the pandemic, this study by Szilagyi and colleagues showed one out of 4 parents in the United States was hesitant about HPV vaccination. but they trust their healthcare provider the most. So this is pre-pandemic data that showed there still was high prevalence of hesitancy among parents and caregivers. And Heidi Larson and colleagues have written this really great paper called The Vaccine Hesitant Moment that attributes vaccination hesitancy, that the convergence with the pandemic was almost the perfect storm or the perfect circumstance because of the introduction of social media several years before and the way in which disinformation is perpetrated across social media platforms. So on social media platforms, there are about 12 accounts that all of the misinformation posts can come back to because it is a coordinated disinformation campaign to try to plant seeds in the minds of those who are questioning or somewhat skeptical to help fuel very weird theories about something that mechanistically or biologically is completely implausible. And one of those examples is the way in which HPV vaccines were somehow linked to issues of fertility and sterility. Mechanistically, there's no way that these vaccines can really result in those particular outcomes, but yet they made people think they could. And that actually is the origin of the COVID-19 vaccine concerns about fertility and sterility. Come back to these concerns that were planted on social media. So here she shows a timeline of how these events all fit together. And so they asked questions about COVID-19 vaccines, measles or MMR vaccines, and HPV vaccines. And you can see here, there is a lot of red across the United States, which indicates high levels of vaccination hesitancy. We have a lot of tools available that we know work. Primarily these tools as shown here from the Community Guide for Preventive Services. There's also the National Cancer Institute evidence-based cancer control programs, but they all address these issues of supply, so access points to actually get the vaccination, and demand, building confidence, normalizing it, and creating linkages that are needed so that we can ensure that there's higher HPV vaccination coverage. An approach that works really well, a strong provider recommendation and a supportive system continues to be the most significant predictor of HPV vaccination coverage. This approach here from Drs. Noel Brewer and Melissa Gilkey at the University of North Carolina at Chapel Hill shows us just how easy that is. Using an announcement or presumptive approach, you note the child's age, you announce that the children this age are due for vaccines, and say you're going to vaccinate today. So here's what it looks like in total. All of these put into practice. This is a very effective way. We've seen 10 plus percentage points change in just this shift in how HPV vaccination is recommended. And this example here is bundling HPV vaccination for HPV cancer prevention in the middle of other routinely recommended vaccines. And I want to bring to attention a strategy we're employing at St. Jude, and that is our public awareness campaign to promote on-time HPV vaccination. Our primary target of Path to a Bright Future is parents and caregivers, but we recognize the ways in which St. Jude can build confidence in the general public, healthcare providers, and those of the age to be vaccinated. So Path to a Bright Future is based on the concept of HPV vaccination as cancer prevention. A moment of prevention today offers a lifetime of protection for the future. And you can check out the campaign, join as a campaign partner, access our resources, let us know if there's a resource that would be helpful to you. We also, on our Path to Prevention website, which is the stjude.org/HPV site, have a fact sheet about HPV vaccination with rural communities with some specific rural data that could be of interest to you too. And while we're working on these efforts, we also have conducted some policy analysis to understand leverage points for improving the policy landscape in support of HPV vaccination. And you can access this report and download it online. But we ended up with 5 of these policy recommendations that offer us opportunities for improvement. So we have to do something. And our efforts to improve HPV vaccination coverage have to include addressing that supply side as well as the demand side. And we also, we have to attend to the potential negative effects that exist, the influences on vaccination hesitancy, and work to build confidence in HPV vaccination as a safe and very effective tool to prevent cancer. And Cervical Cancer Awareness Month, or cervical health awareness month here in January, there's no better time than to add this into conversations to include recommendations about cervical cancer screening and also recommendations about HPV vaccination. And I'm happy to take your questions and do my best to answer those. I also put some resources in the chat for International HPV Awareness Day seminar series that is being hosted by St. Jude coming up, leading up to March 4th, which is International HPV Awareness Day, and also included our website links in the chat. So I'm happy to pause. I gave a PDF of my presentation to Wesley to be able to share. You're welcome to access that. There's a lot of additional information in the PDF version, including more information about our program here at St. Jude, and also a wide range of resources that we have compiled that could be useful to you as well. So thank you, and let's go ahead and do some questions and answers. I'll stop sharing to do that.
Thank you so much. If you have questions, feel free to come off mute or type them into the chat. While people are thinking, I did have one. Is there any sort of discussion or plans for screening related to other HPV cancers?
So there's not. There is a manual oral exam as part of twice annual prophylaxis visit to your dentist that should be done. Your dentist should absolutely be manually and visually checking your oral cavity to make sure that there aren't any suspicious areas, lumps, bumps, or other. But that's not U.S. Preventive Services Task Force style recommendation. It comes from the American Dental Association. We're very grateful that they're doing that. But there just hasn't been. And I should say the reason why we have screening for cervical cancer is, of course, the Pap test was introduced in the United States in the 1950s through Ladies' Home Journal, Good Housekeeping, and other magazines that reached many women who were not in the workforce and were raising families at home at that time. To introduce the idea to them, the American Cancer Society was engaged in widespread public awareness campaigns. That's because at that time in the United States, 100,000 women were, getting cervical cancer each year, not 13,000.
Mm-hmm.
And since that time of widespread introduction of the Pap test in the US, we've seen the number of cervical cancer deaths decline by 75%.
Wow.
And so that test is still in our mainstream. It's become part of our norm. And there are rarely and never screened people who have a cervix out there who we want to reach with this test, but we just haven't seen that same energy. I think there could be changes down the road to oropharyngeal cancer screening, maybe a stronger recommendation from the professional organizations and societies and other groups, but that's really the reason, is because when you think of the origins of cervical cancer screening and the widespread implementation of the national screening program, there's a lot of influence there that's happened over time to offer that type of screening. Vulvar vaginal screening, there's visual exams that get done during a pelvic exam. Anal cancer for females who are going in for a pelvic exam, there is a recommendation from ACOG to manually digitally probe the anal area. So there are those penile cancers. It would just be what you could see on the outside with visual, but none of that is formalized as a U.S. Preventive Services Task Force recommendation.
Thanks.
Are there any differences in screening recommendations or other medical management approaches for adults that didn't have the opportunity to get HPV vaccination, and HPV vaccination might not be appropriate for them?
It's a great question at this time, because in the United States, our coverage has been so abysmal. There have been no changes to the screening guidelines. They have stayed the same regardless of vaccinated or unvaccinated. And that's because HPV is just so common. And while the vaccine works really, really well, it's hard to know with the timing. A lot of children aren't getting the vaccination until much later, until they're 17 before they might go off to college, trade school, or move out of the house. So for that reason, we've just seen those guidelines stay the same. In countries like Australia, which is on track to eliminate cervical cancer by the year 2035, no more cases of cervical cancer there, because they've had such high uptake of HPV vaccination through school-based and other public health-based programs. They have some differences in how they track and manage screening there. But in the US, we have not seen that yet. And that's really attributed to, we just crossed the 50% threshold, which on a national level, with pockets that are far below that. So for that reason, we have not seen energy around making those changes at this time. But let's be hopeful. I'm hopeful that we'll see more coverage, and more coverage means less disease. And that means that we have to take a look at the guidelines when that happens.
We have 2 more minutes. Does anyone have any questions for Dr. Brandt?
Well, if you do have questions in the future, feel free to email me. I'm happy to respond by email, and also check out our resources online at stjude.org/HPV and stjude.org/bright-future. Thank you.
Great. Thank you so much. That was really informative and comprehensive. So I'll send out the slides that you shared with me, and then I made sure to get a copy of the resources that you shared in the chat, yours and Elsa's, and I'll send those out with a follow-up email. But yeah, thank you so much. I hope everyone has a good rest of their day, and we'll end for the day. Unless, Elsa, did you have anything else to add?
No, thank you so much, Dr. Brand, and thank you everyone for the time today. Take care, everyone.
Thank
Bye.
you. Take care. Bye-bye.